Bring this meeting to a start, and I will pass it over to Bobby. Good afternoon to see everyone, or Janine, I don't know.
Thanks. Yeah, I just wanted to make one note that the Board of Supervisors appointed a new beneficiary to the commission, Daryl Lake. This is his first meeting, so I want to extend a very warm welcome to you. And this will be an educational session, but we'll look forward to more discussion during our next meeting later this month.
Thank you.
Welcome, Commissioner Lake.
Errol, do you want to say a few words about yourself to the group, just so they can get to know you a little bit before we start?
Can you hear me first off?
Yes, we can, from your fancy office in your car.
Yeah, right. So my name is Daryl Lake. Lived in Sacramento for about 20 years. I met my wife kind of in a crisis situation. We ended up having a couple of kids. I think one of the things that benefited us the most was our participation in family resource centers. And of course, back then they didn't have guaranteed funding. It was, you know, they never knew how much longer the program was going to last. And since it benefited us so much, I just went out and went to every meeting and every funding opportunity I could to speak on behalf of the program and how much it had benefited my family and I think the other families in my community. And just over time, I started doing a lot of speaking for the children's home and getting involved in First Five. And I sat on the First Five Medi-Cal Dental Advisory Committee until 2016. And I also was a consumer director of the Wealth Space Board of Directors. So I got 3 kids. Of course, my oldest boy graduated from high school the other day, and I have another teen who's going to be a junior, and my 12-year-old daughter who hates me.
Well,
I'm just
Daryl,
not cool anymore.
Yeah, well, you've got great qualifications for this commission, so they're very lucky to have you. Okay, well, we're going to get to work. So I'm Bobby Wunsch from Pacific Health Consulting Group, and some of you haven't had a chance to meet my longtime business partner, Tim Riley, who's going to be presenting also today. Today's the third and last of our educational sessions that are part of our strategic planning process. And today we're going to focus on health authorities in other communities and also on the other county commissions that have overlapping purposes, populations, and services. So Janine, if you want to bring up the PowerPoint, we'll get started. And we'll stop every few minutes, everyone, for comments and questions. So why don't we go on to the next slide, just so everybody can see what we're going to cover today. We're going to kind of cover the history of local health authorities. We're going to give you some examples of local health authorities that operate their own Medi-Cal managed care health plans and those that don't, and the differences. We're going to talk about how these health authorities have developed in terms of funding. And for those health authorities that have health plans, kind of how that has unfolded. And then we'll talk about the Sacramento County Health Commissions and brainstorm some ideas with you about what kind of connection should we have to the ones that are key, particularly in terms of the areas that the health authority oversees. So let's go on to the next slide. And without further ado, here's Tim, and he's going to discuss the first set of slides. And we'll be sending these slides and an attachment, a crosswalk of the health commission's purposes and populations out immediately after the meeting. Tim, why don't you take it away?
Thank you, Bobby. So I'm going to talk a little bit on this slide about the history of health authorities, because I think it's important to understanding what they are and kind of where we are, because they certainly have developed over time. The health authority concept was really developed in the 80s. And the idea was to bring the Medi-Cal program down to a local level and establish a health plan governed by a public board so that it would be a public community plan And really, a little bit of it was, hey, let's take over that state and federal program and run it locally. We have to be able to do a better job than they're doing. And that really was starting the first county organized health systems in Santa Barbara and actually Monterey, which were federal demonstration sites. So there was state statute to authorize counties to be able to create the governance structure for this local plans by county ordinance. And they were specifically designed to be stakeholder boards or commissions, so that you had, again, that community flavor to them, that the community would be advising on how the health plan was set up. And the idea wasn't that these plans would be operated by the counties, but they would be governed in a public setting, and the county supervisors would set up the boards or commissions by making appointments and ultimately holding the authority to expand what they do or actually terminate them, but really wouldn't be operating them on a day-to-day basis. And currently there are 14 health authorities, I believe, across probably more than 20 counties today. All of the county organized health systems were created this way. And again, county organized health systems are one plan, one public plan in a county that is the only plan for the Medi-Cal populations. And just as a note, most of these plans we're talking about today have not just Medi-Cal programs as part of their portfolio, but they often have Medicare, health insurance programs for IHSS members, and in some of their cases, they actually have covered California populations as well. Theoretically, they could have anything. So the county organized systems, Santa Barbara, Monterey, and then San Mateo in the 80s. In the 90s, you had an expansion to a number of counties, and there's been a couple since then. But in the 90s, when the state really wanted to develop Medi-Cal managed care, they eventually settled on the two-plan model that expanded it to most urban areas within the state. And just as a side note, the two-plan model is really a compromise between county organized health systems, which most of the locals wanted to do, and some version of GMC or geographic managed care that the state wanted to do for multiple plans. So the state said, hey, well, we'll set one up when there's one public plan, but there'll be a commercial plan expansion. Those local initiatives were created at that point, all adopted the health authority model, governance model, where their counties passed ordinances based on state statute that created stakeholder boards to, or commissions to advise the development of the Medi-Cal plan and continue to set policy. Contra Costa County is the only one that didn't set up a health authority model. They just used the existing licensed health plan that the county already operated and didn't set up a separate health authority for it. But basically all of the other counties that launched local initiatives in the first wave did so. And as a footnote, I would just say all of those counties that launched them were also counties that had active public hospitals and public hospital systems, which really made the county more of a player in really the healthcare system. And so it was easier, particularly as it relates to funding, to start local health authorities at that time. But since that time, some other counties have set up or started to set up health authorities where they didn't create a health plan. And we'll talk a little bit about that. So next slide, please. Okay, pretty much what I just said. All of the county organized health systems have this governance models, the local initiatives, except for Contra Costa have it. And since that time, there actually have been some created that didn't have a licensed health plan or county organized health system in them. though they did want to accomplish some of the same goals of improving the Medi-Cal program locally. Next slide, please. Okay, well, maybe I'll pause there just for a second. If there's any questions I can ask, and then I'm gonna talk about some examples of both health authorities with plans and health authorities without. Okay, we'll pretend like I was so clear and brilliant that everybody knows everything. There are no real questions, but I'm sure there's some, and we'll get them out here soon, hopefully. Okay, health authorities with health plans. So all the county organized health systems were created with the health plans. County organized health systems are currently exempt from Knox-Keene licensing, but they're subject to all the same requirements by contract. The difference, of course, about county organized health systems is it's actually something that exists in federal statutes as well, and really allows the state to create a single plan without offering choice of other plans. But for the most part, it's just the same thing. It's a governance made up of stakeholders that runs a plan for the Medi-Cal population. And as I noted, all of the two-plan local initiative models, all of the same public health authorities have the same administrative structures. They're all set up by county ordinance based on state statute. And pretty much they also develop full service health plans administered by in-house staff and systems. There's an exemption that I'll get to here in the next bullet. But so for instance, the health plan of San Joaquin, just south of you, and Alameda, south and west of you, are two-plan counties there that have health authorities and licensed health plans. In a later adult development, a few years later, Calviva, a local initiative health authority that operates in Fresno, Kings, and Madera, was created. And that county originally had a couple commercial plans in it, because when Fresno was asked whether they wanted to be a local initiative, there was no community consensus in developing a local health authority. So the state just put two commercial plans there. As years went by, the locals there, led by the county health department, decided, well, we're hearing good things about health authorities in other counties. We'd like to have our own. And so they created a health authority, which couldn't really create a health plan right away. So it partnered with HealthNet to have HealthNet be the plan for them that had the network, could process the claims, and could take on the risks, so it would minimize the reserves necessary for Calviva. But Calviva eventually got a Knox-Keene license, so technically they're a health plan, but they don't have all the direct administrative services provided by their staff. It's all through a contract, primarily through HealthNet. And that's been in existence for a number of years now. Next slide, please. So Calviva sort of started out not being a full-fledged plan, but it decided to become one through another plan, through HealthNet. Though they did have the idea that someday they might expand and have their own staff. They have staff now, they have 18 staff, but a plan their size would have normally several hundred staff. And so, again, as I said, all of the major administrative tasks are done by HealthNet. But Imperial County was in a similar circumstance. The state was going to create Medi-Cal managed care in their county. And they said they wanted to create their own plan, but again, they didn't have the funds available to start up a plan. And really, it would cost tens of millions of dollars to start up a plan at any size. So they created a health authority, got the state to allow them to designate one of the two slots in their community, whoever they picked and not the state picked, Imperial designated Health Net to that slot. They don't have authority over Health Net. They're not the contractor with the state. But to get that designation, Health Net developed a contract with the Imperial County Health Authority, and contained in it are some funds to invest in the community, and there is some advisory role that the locals have to Health Net, but they have no authority because they don't have a contract over the benefit. However, Imperial anticipated that one day they might want to have their own plan. And so that was written into their agreement with Health Net and into their health authority statute. And that's what they're doing now. They're creating a licensed health plan under their health authority because they don't have the funds to develop a full-fledged health plan with several hundred staff and tens of millions in reserves that the Department of Managed Care, the regulatory entity, requires. They're going to, at least at first, and maybe long-term, contract through Health Net, similar to Calviva, to perform all of the administrative functions and to take on the healthcare risk. Keeping open, though, that they might want to, at some point, directly provide those services. As you know, Sacramento created a health authority to provide some oversight over the GMC models. San Diego has a similar thing, but I don't believe they have a health authority. It's just an advisory role. And then I thought I would note that some counties that have public hospital systems decided to move their hospitals outside of the county and into a health authority governance model. And now their public hospitals are run by that health authority. Alameda is an example of that. Alameda's hospital is run by a health authority that the county set up. Kern Hospital is run by a health authority that the county set up. Periodically, there is some discussion of merging their local health authority health plan with their local hospital health authority. Though, as you might imagine, there's quite a few political issues to be worked out in any such arrangement. So, though it's been discussed several times through the years, to my knowledge, that's never really been done anywhere, and I'm pretty sure that's true. Any questions I can answer at this time? Okay, next slide, please. So really, one major item that developed or guided the development of all of the health authorities was development funds. As I said earlier, even the smallest health authorities, if they created plans, would need tens of millions of dollars to start. You have to hire staff ahead of time. You have to buy a HMO computer system. You have to set aside reserves to ensure that you provide care, even if there are unexpected costs. So really that, again, that's tens of millions of dollars, and that's not really readily available in most communities. The regional health authorities all received some seed money from the state or the feds. Certainly all the county organized health systems did. And when they were created in the 80s and into the 90s, things were also cheaper, but they got also some funds from foundations, and all the local initiatives also got some seed money from the state. They, if I remember correctly, each of them got 1.5 million from the State Department of Healthcare Services. That wasn't enough to fully fund their development, but in most of those counties, the county itself lent through a subordinated loan the rest of the development funds to start up. And in every one of those counties, the local initiatives or county organized health systems, if they did the same, actually paid back those loans either on time or ahead of time through health plan operations. I mentioned subordinated loans because that's an important feature of it, because that allows the plans to use a loan to fund their reserve requirements that the Department of Managed Care looks to make sure you have sufficient resources in case you have unexpected healthcare costs. Subordination comes in because it means basically others, particularly in this case, providers, would get paid before the county could get repaid. So there was some risk for the counties in that. But those counties that created health authorities, but not health plans, like Imperial, didn't have those kinds of funds available to start up their plans. So they had to work on other ways to do it. And that was also true for CalViva that we mentioned earlier. It is a full-fledged licensed health plan now, but they didn't have the development funds, and there weren't in those counties tens of millions of dollars available either. So that is why they chose to contract through HealthNet, because that would mean they wouldn't have to buy a computer system. They wouldn't have to hire all the staff. It would already be all set up. So it would be quite a bit less expensive to start up the plan, but would allow them to start influencing the Medi-Cal program within their county, because they would be the actual contract holder, but also they would allow them to build up reserves so they could choose to just contract directly as time went by. And that's what Imperial's doing as well. They don't have sufficient capital to start a plan themselves, but they're going to take that first step of working towards that by getting a license, but operating through another plan. So I'll pause there and see if there's any questions I can answer there. This is actually a lot of history in a very short period of time, but hopefully the general issue is clear. Okay, so next slide, please. All right, so what are the advantages of being a health plan? Certainly, in some of the cases we've already talked about, health authorities that, while they're not a health plan, they chose to influence how Medi-Cal was provided in their community in an advisory role or contracting through a third party, which they certainly can do. But as a full-fledged licensed health plan for the state, or a separate authorization as a county organized health system, you really have more control over member issues, quality, network policies, and any initiatives developed or approved by the commission. You can invest surplus dollars in member benefits or your provider network. Often the public health authority plans pay providers more than their competing commercial plans. Not always, but often. And of course, that's because they don't really have any shareholders that they need to save their surpluses for. It's really community money at that point, and they have to decide how best to spend whatever community money they have after they fulfill their reserve requirements and their day-to-day staffing requirements. So those savings can be retained locally and then decided upon by the governance, by the health authority board or commission. And then the other advantage of being a licensed health plan is you can add additional products. You can add a healthy kids product that no longer is needed because kids in California are pretty well covered by other programs, but wasn't that long ago that throughout the state there were healthy kids insurance products being offered. All of the other health authorities had their own. You can join Covered California, as I mentioned. The state is going to require that all the health authorities become DSNPs, which is a Medicare plan for dual eligibles, dual Medicare and Medi-Cal eligibles. So that's something else, and that's really adding people to the same, that are on the same continuum in your community, Medicare recipients that have both Medi-Cal and Medicare, as well as regular Medi-Cal recipients. And so at Covered California, in some ways, is the same, because many people that are covering for Covered California sometimes bounce back to Medi-Cal, depending upon their employment status and other issues. And certainly it's, I think, helpful for a local plan to provide health insurance coverage wherever their community needs it, and you have that power as a licensed plan. Next slide, please. Okay, so challenges to being a health plan. Just bring this up since I was just talking about the advantages. And this is why everybody hasn't created their own health authority health plan, even though most communities that I'm aware of, they're all happy, or at least they're pleased that they have a plan, even when it's not perfect. So the challenges, you can do it through a county organized health system model. There you have to get federal legislation adopted to put you into federal statute that specifically allows it. That is not an easy thing to do. It's not impossible, but it poses problems. And it would also pose problems in an area like Sacramento that already has a number of operating Medi-Cal plans. And the state is now giving out a new 5-year contract. And so someone would have to figure out if they wanted to do a county organized health system at the state, and if so, how they would transition from the existing model. But the development costs and the reserve requirements are really the biggest hurdles for getting a new county organized health systems or getting a license to the Department of Managed Care, because there's significant costs there. I've touched on this several times, but I think it's a real practical consideration for anybody even mildly consider developing a plan. I was a CFO of a couple different plans, so I'm probably a little fixated on cost, but I do think it's important because it's really the only way you can move forward. DHCS would have to approve that approach. They would have to figure out where in Sacramento a new plan would exist. Would it replace all the existing plans? Would it be one of multiple that were competing during the next procurement cycle? Or would they just automatically give a public plan slot while the others still competed? Any of those scenarios would significantly limit enrollment, even if the plan was really good, and it would take years to draw away from the other plans to build up a substantial part of market share of the Medi-Cal enrollment. I might add that, as I noted earlier, county organized health systems have all the Medi-Cal recipients in their counties, but the local initiative health plans have between 70 to almost 90% market share in all the counties where they're competing against commercial plans. So they've done very well, but they started at the same time as the commercial plan, so they didn't come into a new market for them, which was an old market for a number of other plans who already had all the enrollees. So as you can imagine, that would be a pretty big challenge. Also, DMHC, the Department of Managed Healthcare, is the regulatory entity for health plans in the state. And so there's a fairly rigorous application process that the new plan would have to go through. Certainly something all the public plans achieve. So that's not that's not an impossible standard, but again, it's an undertaking that would take usually more than a year to complete. And really is true with all these things, you need substantial local support and approval to undertake any of these actions. Certainly, the county has to be in support of that. Because I might add, all of these choices are because the state and the State Department of Healthcare Services has chosen through the years to allow counties and local communities to have some influence on Medi-Cal managed care in their communities as exhibited by Board of Supervisors resolutions asking for whatever model they're trying to go forward. So that's always been a really important part of developing any kind of local health authority health plan. Okay, well, I think we can move on to the next slide. And I believe that is Bobby's slide, so I'll turn it back to her unless there are some questions I can answer first.
Yeah, any follow-up questions on the health authorities before we move on to commissions?
I
Tim,
do
are
have
any-
one
are any
question.
models more successful than others?
So is the question, are any of these more successful than others?
Yeah.
So I think in general, most communities prefer a county organized health system single plan model. Most really pretty consistently, people prefer a public plan. Not because they think it's perfect, but because there is some direct influence by the community in that case. There's stakeholders on the board, there's other leadership on the board, and any profits are reinvested in the community. But the other advantage, particularly for providers and to a certain extent for members too, is that in a county organized health system, there's only one plan. There's really not a lot of advantages to providers, to physicians, to have 5 plans in your region. It's not that the plans are substantially different. It means you might have to get contracts with multiple plans. They might have 5 different formularies, 5 different quality programs, 5 different ways of submitting bills. So there's no real advantage to most providers in that case. And really, there's not really an advantage to members either, because there's more people to figure out, well, how do I join this plan and how do I utilize services within this plan? And with the exception of Kaiser, when there's multiple plans, they're all sharing the same physicians. So a new plan isn't really offering new choices for members. It's the same physician choices, but they're just having one or more contract in different plans. So there's not really an advantage to members in that case. So a county organized health system is really the simplest model. And so I think people really prefer that simplicity. But the 2 plan ones are similar, and they've succeeded through having more members choose them, usually at a pretty high rate, at least 2 to 1, sometimes even 4 or 5 to 1 over the commercial plan. And I would say, and this is less clear from what I was just describing, but I would say that's because they have many of the same features. They're local, they're invest their profits locally. But it's also, they're closer to the community. They're closer to the providers. They've tended to be the home of the safety net providers, not exclusively, but certainly the majority of often public hospitals or FQHCs or other traditional providers always have a home in the public plans. And they're connected to community groups, to CBOs and others a little bit better, which helps put their name out into the community and really helps facilitate people deciding to join them. That's not to say they're perfect, and over time they're going to have different troubles and be more successful or less successful. I would say, I like to joke that you end up with the local public plan that you deserve, because it's really the community running it. And if you don't like it, we'll do something about it. Within the practical confines of actually having the responsibility. It's easy to criticize people when you're not responsible within a certain set amount of dollars of making it work. So it's a little bit more challenging when you have the responsibility, but I think most of the communities are glad they have chosen to do that. None of the health authorities have ever been voted out of existence by their county board of supervisors, though there was a health authority originally in Monterey, not the current one that's in the county organized health system through the Central California Alliance that went bankrupt in 18 months in 1983. Nobody hears about it anymore, but it did go out of existence. But Monterey has always been somewhat of a managed care graveyard. So that wasn't terribly surprising. And there's a few papers explaining why that happened. I don't know that it's relevant today, but in any case, so in my opinion, there's really three answers to your question. That the having a single plan, people seem to prefer. Having one plan or even two plans, they prefer over having 4 or 5 plans, like GMC, and that really each of those plans, each of those public authority plans, is shaped by their own community. They're shaped by the people on their board. They're shaped on how integrated are they. Having participation in the creation of a number of these, I'll say, and maybe I'll say this because you're all from Sacramento, I helped create health authorities across the state. Those created in very conservative areas, Orange County, some places south in the Central Valley, which are more conservative communities, were more difficult because there wasn't quite the same view of setting up a program for the Medi-Cal recipients. And there, so it led to a different flavor to the health authorities. And some communities, not specifically those, also, the providers didn't get along, or the providers didn't get along with their county. Now, I would say in almost every county I've been in, the county doesn't have a perfect relationship with the provider community, because often the provider community looks to the county to be a funder of healthcare, and counties view, well, we have limited resources, we can't do everything everybody wants. But some communities are better at working through those issues than others, and that ends up flavoring the kind of health plan you have and the politics you have later, because the politics of your community don't go away when you create a plan. As a matter of fact, in some ways, they become the focus of whatever political discussions were had before about healthcare. So there is some individual community variation just based on those kinds of things. I don't know, I hope
Thanks,
that
Pam, for that question. Yeah, I would just add one more thing before we talk about other boards and commissions, and that is that we have 3 counties currently that are going to become single plan counties: Alameda, Contra Costa, and Imperial. They will not be county organized health systems, but the state is requesting authorization from CMS under a 1915B waiver that those 3 counties who volunteered to move from a 2-plan counties to a single plan will move over. Eventually, they all want to get the federal designation of a county organized health system, but that takes time, as Tim mentioned. So that's just another variation on the single plan. Daryl, it looked like you wanted to raise an issue.
Yes,
Please.
I do have a question. So you said that one of the challenges when you're switching over is having cash reserves and financial concerns. If we're in a GMC plan now in Sacramento County and we were switched to that, in the transition process, what happens to the members, the beneficiaries, the people who are currently under current treatment, you know, that have active referrals, or you know, because that, like you stated, that's a huge issue already with some providers where they have to deal with all the different plans. But if you were making that transition, where does that leave the members and, you know, the beneficiaries in their treatment while that transition is happening?
Sure, that's a very good question. And there are basic two things that the state requires in any transition, like where you're going from multiple plans to a single plan, or you're just transitioning plans. One is that the new plan taking over is required to put together a network that is sufficiently large to meet the needs of their population. And further, that it has as many, if not all, of the existing providers in the other networks that exists. And to further reinforce that, they put in a continuity of care policy that requires plans, the new plans taking over, to varies a little bit from specialty and other issues, but basically for a year, guarantee that members could see the physicians they were seeing before, even if that new physician doesn't sign up with the new plan. So that the plans are required to try to get all of the existing physicians, I'm just going to use physicians, but this applies to all providers on some level, into the plan, into their network, and that further, whether or not they succeed, that at least for a year, they continue to pay those providers. And quite frankly, for all health plans, health authorities, commercial plans, or whatever, the Medi-Cal population really is a continuous challenge to get enough providers, to get enough physicians into it. You're always working on that problem. But anyways, that's how the state approaches transitions, and that's certainly how the plans want to too. They want to maximize the existing relationships, and then in that case, the members are given a choice. You can pick a new provider out of this network that's been put together, or you can stay with your existing provider if it's in the network, and you don't have to do anything to stay with that provider. Try to minimize the confusion to the community out there, because you don't want people being reassigned to somebody else because they didn't make a choice because they didn't understand what was going on.
And we anticipate, although we don't have guidance yet from the Department of Healthcare Services, that that's the process that will be used in Sacramento County if Sacramento County actually goes from the current plan numbers down to 3, including Kaiser as under the statewide contract. So you'll be seeing that in action at the last quarter of 2023, when that transition presumably will occur. So I want to, just in the sake of time, just talk for a few minutes, because I know we need to have public comment. We did an analysis of 15 related Sacramento Health Commissions and boards that had overlapping purposes, or intersecting purposes might be a better word, with the Health Authority Commission. And you can see a list of those here. Everything from the Children's Coalition to First Five, to the HIV Planning Council, IHSS Advisory Committee, the Maternal and Child Health Advisory Board, the Mental Health Board, the Dental Advisory Committee. And right after this, Janine will be sending out to you all not only the PowerPoint, but a crosswalk that we did that shows the name of the commission. These are all Board of Supervisors appointed, the purpose of each of these individual commissions, and where it overlaps with the authority of the Health Authority. If we go on to the next slide, what you'll see here is, we can look at these commissions and boards in 2 different ways. What populations are they serving that are covered by Medi-Cal managed care? And what services are they focused on that are also part of Medi-Cal managed care? And you can see there's a lot of overlap on older adult issues, particularly as Tim mentioned, the expansion to the dual eligibles, children and youth, obviously so much focus from a population point of view, people living with disabilities, and then on the services, behavioral health, HIV/AIDS, dental care, obviously primary care, and in-home supportive services, even though in-home supportive services is provided only to Medi-Cal beneficiaries, it's not a covered service in Medi-Cal managed care. So there's lots of intersecting issues that you might face. And if we go on to the next slide, I think one of the things it would be great for you all, the commission, to start thinking about as we work on our strategic plan in the coming weeks is what kind of connections or communication does the health authority want to have directly, indirectly, with these boards and commissions? How do we make sure that what they're learning about the populations they serve and the services that they are working on, you can also learn from, and vice versa? And, just in the few minutes that we have, it might be helpful to hear from any of you that have any thoughts about this. Some of you have served on some of those commissions and do a great job of representing those issues on the Health Authority Commission. But do you as a commission want to think about how do we formalize relationships with these 15 commissions and boards? It's a lot to think about. How do we have a liaison? Do we have staff connection? What's the best way to keep the lines of communication open? And I don't know, in the moments that we have before we go to public comment, if anybody has an ideas that they'd like to put forward about what kind of formalized communication there might be considered, so that we can incorporate that as we're thinking about the strategic plan. Anybody have any thoughts on that?
Just to say that, Bobby, that I'm excited and appreciate that you brought this up and went in to look at these, these other, commissions that are operating within the county that do have this overlapping mission with us in many ways, or intersecting mission. I definitely think at a minimum, it's a great place to, potentially pull in, obviously additional ideas and additional feedback, but, if, possibly, we're going to have to potentially fill new, the board will be appointing new commissioners at some point, right, as well. And so, this is potentially a pool of talent that we may want to bring in here. But I don't know exactly what it looks like, but I do feel like I like the idea of, trying to formalize, somehow have some sort of communication or, work with these groups, given the fact, maybe they could share with us what they're working on or something, and then we can see how that fits in, or I don't know, but I'm going to think about it because it's good.
Yeah, no, those are some great ideas, Eddie, and I think we do need to think about in the strategic plan, at least having a strategy to formalize the relationships. Maybe we won't have the details of what that looks like, but that could include, reviewing their minutes, them reviewing yours, staff liaisons, MOUs. There's a lot of ways to do that. I love your idea about a potential breeding ground for new commissioners as the commission goes through changes, because obviously these are people that are already committed to the work in many different areas. Anybody else have anything they want to add in terms of ways to connect to these commissions and boards?
So from my experience on the Dental Advisory Committee, one of the things that kept popping up was how dental would be part of the overall, your overall health, how it would be related, just like, going to the doctor for a broken arm, or integrating that with other, transportation services, or just issues where dental and other health issues intersected. And I think that is a great idea, because if we cannot, that would have been so much more helpful. And I know we said it over and over again that we would have loved for the health plans to come and sit on the committee and address the committee, so that we could have that discussion of, that being part of, covered services, because that was the issue, was coverage of services. So
Yeah.
I think great idea somehow to integrate everybody, because from the list of commissions I see, those are all serious issues that aren't currently being addressed by the health plans in place. So.
Yeah, Daryl, I mean, it's great that you've had all the experience that you've had, and dental's a really good example because the Medi-Cal managed care plans that are overseen by the health authority do not include the dental part of the Medi-Cal program called Denti-Cal, only those dental services that are provided in the hospital. And so, as everybody knows, you know, the Medi-Cal program has many silos, one of which is the medical care silo that the Medi-Cal managed care plans are generally responsible for, including the mild to moderate behavioral health. We have the Denti-Cal program, which sits on its own and has two components. And then we have the mental health managed care program that's operated by the county for the seriously mentally ill, and the services for drug and alcohol services. So, I mean, there's lots of intersection, and there's these silos that exist about what the Medi-Cal health plans are responsible for. So it's hard to provide what we would all think of as comprehensive whole person care in this system, which is why communication with these groups, as both you and Eddie mentioned, really is important, and where there's a lot of expertise around important issues that certainly could inform the work of the health authority. So I think as we go forward with strategic planning, this is something we'll wind our way back to. And in the interest of time, I'd just like to go to the last slide, just as a reminder to everyone that our second strategic planning session will be June 21st from 3 to 5. And the one after that will be July 19th from 3 to 5. We've got a great setup for our next strategic planning meeting. Appreciated everybody's surveys, and County Council won't allow us to share the survey results until we get to the meeting, but we've already incorporated great feedback into the next round of materials, which we will send out in advance of the meeting. So you should look for those next week. And with that, I'd like to thank everybody for participating and turn the meeting back to Eddie.
Right, thank you, Bobby, and thank you, Tim. Really appreciate it, and appreciate everyone for participating. Now is the time for public comment. So if there's anyone, non-commissioners in the public that would like to make public comment, now's the time to do so. If you could raise your hand or send up a smoke signal, and we'll gladly hear from you, recognize you if you'd like to make a public comment. Anybody? I'm not seeing anybody, I don't believe. I don't see any hands raised. So without further ado, then I think, really appreciate Bobby and everyone, and welcome Daryl on your first meeting. Thank you for being here, and very excited to have you as a part of the commission. And we're adjourned. So we will see you all on June 21st, 3 to 5, hopefully.
Thanks everybody. Bye-bye.